Hello, everyone. Welcome to the Flint Community Webinar, your community resource. We are so excited and we have a really wonderful lineup for you today. These are some of my most dear populations to talk about. We're going to be talking a little bit about prostate cancer and social determinants of health, and then we're going to talk about voices of Black women with the American Cancer Society. To help us think a little bit about prostate cancer, we've got Dr. Sean Ogunwobi, who's our chair of the Department of Biochemistry here at the College of Human Medicine. We've got Dr. Kent Key, who's going to help us understand the social determinants of health. And we've got Dr. Javon Gill, who's going to help us understand what that means when you're out going to see your primary care doctor and what questions you should be asking to understand prostate cancer a little better. And then we've got Megan Landry with the American Cancer Society, who's going to talk to us a little bit about the Voices of Black Women initiative and talk to us about a little bit of a few resources that the American Cancer Society has to help navigate prostate cancer. So wonderful lineup for you today. Let's get started. Hi, Dr. Sean.
Good afternoon.
I'll let you share some slides, and you're going to talk to us a little bit about sort of the science behind prostate cancer and how that works. So thanks so much for being here today.
Yes, my pleasure to be here. Good afternoon, everybody. As was mentioned, I am the chair of the Department of Biochemistry and Molecular Biology at Michigan State University. So my research focuses on, among other things, on prostate cancer. And we're looking at molecular mechanisms that underpin the adverse outcomes that men of African ancestry face in prostate cancer, I should say. But today, I would like to share some things that are of general interest, and then towards the end of my conversation with you this afternoon, we'll talk about some of the issues that merit research and why my lab is looking at those issues. So just a slide here to disclose some of my connections with industry. And so let's get into the prostate. So the prostate, as you can see in the image in front of you, is a gland in the male reproductive system. It's located just below the bladder, and it's located in front of the rectum, which is a part of the intestinal system. It's about the size of a walnut, and as you can see, it surrounds the urethra. As far as its function, it produces fluid that makes up part of the semen. So this gives you a general idea of where the prostate is located and its function. And then on the next slide, we have an image of a normal prostate on the left, but a normal prostate could become enlarged. And that tends to happen with age. So an enlarged prostate may block the flow of urine. Because remember on the previous slide, and you can see it on this slide too, it surrounds the urethra, which is the passage through which urine passes from the bladder to the outside. So if the prostate gets enlarged, which may happen with age, it may block the flow of urine, and it may also cause problems with sexual function. Now, when the prostate is enlarged, that's a condition called benign prostatic hyperplasia. And again, that's likely to occur with age. It's not cancer though, but it's important for us to mention it because it may present with symptoms which may be similar to those someone will present with if they have cancer. Plus, it tends to, especially with age, tends to be a precursor or something that would happen before someone may later on have cancer. Surgery may be needed to treat benign prostatic hyperplasia, similar to what may be needed if somebody has cancer. So on our next slide, I want to talk about prostate cancer itself. So this is the disease in which the normal tissue of the prostate or normal cells in the prostate, they change and become cancer cells. We'll show on a subsequent slide that this is really a common disease in men here in the United States. It's the most common cancer that's diagnosed in men in the United States. and it's the second leading cause of cancer deaths. So it's actually a significant problem. It is more common in older men, and the majority of prostate cancer actually grows slowly, although there is a subset in which it grows more quickly or more aggressively. Now, because it grows slowly, majority of men, most people will not die of prostate cancer. It's also important to mention that finding and treating the disease may or may not be important. It depends on whether it's going to be slow growing or aggressively growing. But given that aggressively growing disease has particularly bad outcomes, we will talk about screening so that we can find and treat the disease early. On our next slide, this gives you an idea of how prostate cancer compares with other cancers. And as you can see, it's the most commonly diagnosed cancer in men, period. And in terms of the outcomes, is the second most common cause of cancer deaths in men, second only to cancer of the lung. And to give you a little bit more context, 1 in 8 men will actually be diagnosed with prostate cancer in their lifetime. So again, fairly common. And in terms of outcomes, 1 in 41 men will die of prostate cancer. So this is really something that we as men should be concerned about. In terms of something that's of particular interest to me as a researcher, is this bullet point that tells us that men of African ancestry suffer a higher incidence or development of the disease. You can diagnose the disease more commonly in men of African ancestry, and the outcomes are worse in men of African ancestry. There's much more deaths, twice as much in men of African ancestry than in men of European ancestry. And so this is a disparity both in incidence and in outcome. Why is there such a disparity? Well, researchers like myself are very interested in this, and we're looking at the interplay of multiple factors, including unequal access to healthcare, including differences in lifestyle risk factors. And for biochemistry, molecular biologists like myself, we're also looking at differences in intrinsic tumor biology. So some of these prostate cancers are actually biologically different. We have evidence that some of those biological differences in the prostate cancer may result in differences in outcomes and responsiveness to treatment and things like that. But we'll come back to that in a few minutes. For now, though, I want to talk a little bit about risk factors for prostate cancer. There are several. As you might have picked up from my prior comments, age is clearly a risk factor. The older you get, the more likely you will get prostate cancer. The other thing that many of you may already know, just from life experience, is that family history of prostate cancer is a risk factor. So if people in your family have previously been diagnosed with prostate cancer, maybe a dad, an uncle, a brother, then that becomes a risk factor. The other thing that you have likely picked up already from my prior comments is that race is a risk factor. So again, men of African ancestry, the disease tends to be diagnosed more commonly in us, and unfortunately, outcomes also tend to be worse. So race is clearly a risk factor. And hormones, particularly testosterone, it's a risk factor because the prostate responds to that, it grows as a result of that. And so that's a known risk factor. The other risk factor that's been known, and this is from research, is vitamin E. There was a study called a SELECT study, the Selenium and Vitamin E Cancer Prevention trial, that actually made a surprising finding that vitamin E consumption can increase the risk of prostate cancer, and that risk continues even after individuals stop consumption of vitamin E. But this is information that you can glean from the National Cancer Institute website. The other thing that's interesting as a potential risk factor is intake of folic acid. Now, what's interesting about this is they found, and again, this is from a study, actually a study that took place over 10 years, they found that there was increased risk of prostate cancer from taking 1 milligram supplements of folic acid, right, the supplement. However, the risk of prostate cancer was lower in men who had enough folate in their diets. So good diet is protective, is helpful. However, in this particular case, consumption of this folic acid supplement may not be helpful. Just something to keep in mind. And then the National Cancer Institute also talked about consumption of dairy and calcium being potentially risk factors as well. What about protective factors? A couple that we can mention, folate, right? Folate could be protective, so eat a balanced diet that includes folate. And finasteride and dutasteride, these are drugs that can help, especially in folks that have enlarged prostate glands. They help shrink the size of the prostate gland. They could actually be protective, although it's unclear if they will lower the risk of death from an individual who already developed prostate cancer. Okay, so what about screening? We talked about detecting early and treating early, you know, may or may not affect outcomes, but it definitely will affect outcomes for someone who ends up developing aggressive prostate cancer, which is the smaller subset. The majority would develop disease that's slow growing. But you know, it's unclear who's going to develop aggressive prostate cancer. Therefore, it's very useful to participate in prostate cancer screening. That's been encouraged now, starting from the age of 45. So one common way of screening that many of us who are of that age may have experienced is a physician examining prostate through our rectum. And so this picture shows you that when they do that, they're really trying to get at the prostate. By, you know, putting that finger in, they can examine the prostate and get a sense for whether it feels normal or not. But more commonly, many of us, again, once we get to 45 years of age, we may have been offered, or we can ask ourselves to receive the prostate-specific antigen test. It's a serum test. They draw blood and they can check your PSA or prostate-specific antigen. In some centers, particularly where the PSA test is, you know, maybe there are questions about how to interpret the test. If your doctor may ask for a prostate cancer-gene 3 RNA test, which is a urine test. And so that's something to keep in mind as well. Importantly, many other screening tests are being developed, and part of my research is to look into how we can have a better screening test than prostate-specific antigen tests. So the PSA test is the most common test, and we encourage you to avail yourself of that if you're 45 years of age and above, because it could be helpful in picking up the potential for prostate cancer. But it's got some flaws, and we'll talk about that in the future. And that's something for us as researchers to address. And my research is interested in looking at developing a test that's even better and more effective in identifying disease that warrants treatment. So that's about prostate cancer screening. Let's talk about diagnosis, because you know, screening may or may not pick up disease. But ultimately, to diagnose disease, what's considered by many physicians to be gold standard is a prostate biopsy. And so this is what it looks like. It can be guided by ultrasound, so they can locate the prostate. And then there's a needle that goes into the prostate. And you can see that that needle in the image that you can see there is actually, because they can visualize the prostate, they can also visualize the cancer or the tumor, the abnormal part of the prostate, so they can put the needle directly into that abnormal part of the prostate and take a biopsy. And then that biopsy will be subjected to further testing, histology, and then there is what's called Gleason scoring, which allows your doctor to know the grade of the disease, whether it's low grade or high grade, and that gives them information that can inform their the decision about treatments and so forth. So this picture gives you an idea of what will take place if that was recommended to you. In terms of treatment, there are many treatment options. So again, for slow-growing disease, actually may be recommended that you know watchful waiting may be recommended, or active surveillance. So that's recommended. That's not because your doctor doesn't care, but that's actually a legitimate treatment option. They don't want to treat disease that's not going to cause significant harm to you, because if treatment is offered when you don't really need treatment, the treatment itself may be more harmful than watchful waiting. So just keep in mind that that's an option. Similarly, the surgery, radiation therapy, or radiopharmaceutical therapy, hormone therapy, chemotherapy, targeted therapy, immunotherapy, and bisphosphonated therapy. So we have a physician that will talk to you later. They can maybe clarify what these options are and how decisions are made as to which options are going to be most helpful and which ones you probably shouldn't consider. And just at the bottom of the slide, you'll see that there's continuing research to evaluate additional treatment options that may be more effective, that may have less side effects, and so that's something else to keep in mind. If you have the opportunity, individuals that have prostate cancer, there may be an opportunity to participate in clinical trials and actually gain the benefit of a new treatment that's been tested, or contribute to the body of knowledge that can help inform better treatment of other people that deal with this issue later. So I do want to talk a little bit about the surgical option. So this illustration shows you that if the disease is confined to the prostate, there's the opportunity to remove the entire prostate as part of an intention to actually bring about cure. So this can be done through a variety of procedures that are illustrated. A couple of them are illustrated on this slide. And so it's possible that your surgeon may discuss these kinds of options with you. The other surgical option I want to illustrate on the next slide is one in which not the entire prostate is removed, but a device is put into the urethra to just take out the portion of the prostate or resect the portion of the prostate that's diseased. This approach could also be used to treat benign prostatic hyperplasia to basically reduce the size of the prostate. Okay, so in terms of my research and why I'm interested in researching prostate cancer disparities or prostate cancer equity, we talked about the disparity in incidence, right, or in development or diagnosis of the disease. Is much more diagnosed in men of African ancestry, and even much more so are the outcomes disparate. Men of African ancestry suffer significantly disproportionately from mortality or death from prostate cancer. And we talked about how we don't fully understand all the reasons, but research is looking into an interplay of multiple factors, including unequal access to healthcare, differences in lifestyle risk factors, and biologists like myself are also looking at differences between the prostate cancer itself from individual to individual and in individuals of different racial groups. And now the difference in intrinsic tumor biology may account for differences in aggressiveness, differences in outcome, and differences in responsiveness to various therapeutic strategies. The other piece that's of interest and driving my desire to research this area is we know that the science and medicine are advancing, You've all probably heard of something called precision medicine, in which we're able to, based on our understanding of the biology of disease, we're able to develop very specific strategies that are precise and help us to effectively address disease based on our understanding of this biology. Well, researchers like myself are concerned that if these kinds of research are not made available equitably, in other words, if all populations are not involved, so that we understand the biology of disease in all populations, only those populations that are being studied will benefit from the benefits of these new advances. And so we see the importance of equity in precision medicine, or equity in the administration of precision medicine, both at research level and at intervention level, in order to avoid exacerbating cancer health disparities. And so the last point there says equitable precision medicine can reduce cancer health disparities and promote cancer health equity. And the conduit that will lead us to that outcome is research that's equitable. In other words, research that involves studying disease biology across various populations, understanding the commonalities and any unique differences, and looking at creating interventions that precisely address those unique drivers of disease in various populations so as to improve outcomes across populations. The other factor that's driving my interest in prostate cancer health equity is related to screening. So I'd mentioned how digital rectal examination can be used by a physician to try to get a sense for whether your prostate is normal or not. But I also talked about how more commonly many of us, once we get to the age of 45, we will have the opportunity, and we can ask for the opportunity to do a test called prostate-specific antigen. It's a blood test or a serum test. That's what we have, and it's very useful. But research has shown that we can and should develop a more useful tool, because prostate-specific antigen has issues related to specificity. So it's not only prostate cancer that will lead to elevated prostate-specific antigen. There are other issues that may affect the prostate that could lead to that. So the problem that's associated with this issue then is that it's very possible that an individual with elevated prostate-specific antigen who then has to do a prostate biopsy will do a prostate biopsy and find that they don't actually have prostate cancer. Now, on some level, that's good, but think about if we end up doing a lot of those kinds of biopsies and towards the end of discovering only a few prostate cancers, right? So that becomes a concern if we think about the fact that prostate biopsy itself could have some side effects, infection and things like that. So these are issues that we're weighing as researchers, and we're looking for, can we develop a better screening tool that will have a better specificity and better sensitivity so that we can minimize the number of people who end up having prostate biopsies that are unnecessary. So that's sort of an area of research interest for myself and my laboratory. The other aspect of interest to us is how we came to accept prostate-specific antigen as a way of screening for prostate cancer. The process did not include research in diverse populations. Mm-hmm. The prostate included research mostly in populations of white men. And so it may be a test that works better in them, which is good for that population, but can we, in the development process for new tests, can we ensure that we're testing all populations, and particularly populations that are disproportionately affected with higher incidence of prostate cancer and worse outcomes? Can we make sure that they're included in the development process for new tests? So my lab is looking at developing new prostate cancer screening tests. And in the process of doing that, we're looking at making sure that we're doing this testing and validation across all populations so that we can establish its utility across populations of men throughout the world. And so we believe, based on our research and the research of others, that what we really need is a test that can accurately diagnose aggressive prostate cancer. So again, we're mindful of the fact that a majority of prostate cancer is actually slow growing, right? And so even if it's discovered by PSA testing and prostate biopsy, we're mindful of people being treated for disease that, as we said, your physician may actually encourage watchful waiting or active surveillance if they think that your disease is not aggressive. So how nice it would be if there was a screening test that could actually tell them that from the beginning, right? So that you don't have to go through some of the more painful processes before coming to that conclusion. So that's the area of research that we're interested in. Other people are interested in it in that field as well, and we think it's an important aspect to focus on. And I'd love to hear your thoughts during the question and answer portion of our meeting this afternoon. With that, I would like to acknowledge the members of my laboratory that are involved in the kind of research that I talked about. And it's a kind of research that you really can't do alone, either as a single investigator or even with a laboratory. It's the kind of research that you need to collaborate with many other laboratories across the United States and even across the world. And the kind of work that does require significant research funding. So I'm also very grateful to all the organizations that have funded our research over the years. Thank you again for this opportunity to come and talk to you, and I look forward to your questions and comments and some very robust conversation.
This was such important information. We really appreciate you sharing your expertise. I want to keep you here and bring Kent Key forward, because one of the questions in the chat is one of the questions that I'd really like to expand on a little bit. And it's that concept that you described, Dr. Ogunwobi, not just of an increased incidence among people with African descent, but the increase in mortality. And you didn't use this word, but I would also suggest that oftentimes there's an increase in morbidity. So the outcomes that result are not necessarily not just death, but negative outcomes is what we talk about when we talk about morbidity and mortality. And Kent, I'd like you to think about and talk to us a little about, in the context of your expertise with social determinants of health, what are the social factors that sort of create these increases in morbidity and mortality among our populations specifically?
So historically, and first of all, hello, everybody.
Hello.
Historically, specifically with the African-American community, social factors such as housing, transportation, safety, diet, income, education, and education is not just the level that you graduate, but it's literacy, right? And the ability to really comprehend terminology, especially health terminology, right? And then social support systems. Those are some of the key elements that have definitely impacted African Americans as it relates to the overrepresentation of African Americans across health indicators, having higher rates or higher disparities than our European American counterparts. Another very important piece of that is also clinical care and access to clinical care and to and that coverage, because historically there is still some stigma around really trusting the medical community. You still hear that amongst, different African-American members throughout different, communities, whether you're in Flint, Detroit, Chicago, et cetera. And a lot of that is based on the historical trauma of unethical treatment. And so when you think about discrimination and the isms, racism, sexism, ageism, classism, all of these things playing a factor in this, it is not surprising that we still, even in 2024, see that African Americans still bear the brunt across most disparities, across most indicators. We're just having a conversation with a young lady who's has breast cancer now, and I was giving her the information, and she was just floored at the fact that more European American women get breast cancer, but more African American women die from breast cancer. So these are the types of disparities that are real and in our lives every day.
I want to talk to both of you about this question that's in the chat around precision health, right? So precision health, for those of us who have been really adjacent to it, may not be new, but for communities, it might be something that we're not as aware of. And some of that gets at what you just described, Dr. Key, on access to education and awareness, right? So if you aren't aware of new studies that are in the space of precision health, you might not have access to them. The data might not be as diverse. So Dr. Ogunwobi, can you describe what precision health means for people who may not understand or have an awareness of it? And then Ken, I want you to talk, Dr. Key, a little bit about why it's hard for people to get access to information like that. Why don't we know what precision health is as a community?
Yeah, thank you. It's a very good question. It's sort of a new advancement in medicine, if you will, in which it's now understood that one size doesn't fit all, right? And in order for us to give the best care to individuals, we need to understand the particulars of their disease. And we've come to understand that, you know, a disease like prostate cancer, it's actually within that disease, there are many sub-diseases. Right, and then from one individual to the next, there are unique differences actually. And so we've come to understand that the more we understand the particulars of one individual's disease, the more precise we can make the treatment. So when there are multiple treatment options, including medication, which particular medicine directly will be more directly effective to a particular individual's disease. It may have the same name, but you know, we need to match the treatment options accordingly. And that sort of, you know, in simple terms, that's one element of precision health. Now, just real quick, that's a great thing if everybody has access to it. That's a great thing if the underlying scientific information that's leading to those decisions was gained in the context of studying all of the diversity of the disease. It starts to become a little bit problematic if the underlying information that says, you know, medicine A will be good for someone that has such and such, if the underlying research wasn't done in such a way that what might be unique to certain people was also understood, so that we can understand if medicine A would be good for them as well. So that's the area that we as researchers are interested in studying and understanding how to be more comprehensive in gaining all of the underlying information so that more people in populations throughout the world will be able to benefit from precision medicine.
Thank you. And Dr. Key, what can we do to make the work of precision health more reflect our communities and what our communities need? And how can we do a better job of educating communities on what precision health is, what their opportunities are for getting involved? What should we be doing to make it more accessible?
So there are several things that I think we need to consider doing at the same time. It's not like a step one, 3 steps and we figured it out, right? So one, we need more physicians of color. We need to make sure that we are impacting the medical workforce in a way that decreases the disparity that we see with overrepresentation in the disparities, but underrepresentation in the public health and medical workforce. That's one thing. And that is by providing early access and early exposure to these fields, to urban communities, to communities of color, to youth of color. Secondly, we have to be more, and then we have to build relationships with those communities. You know, when I was growing up, and it wasn't that long ago, my grandmother and granddad knew their position. They went to the church where they went. Like, there were relationships. It wasn't a position that traveled 30 miles from the suburbs into the inner city. You know, there were authentic relationships that, and that physician took care of your grandma, your parent, and you. It was an intergenerational type of relationship. That needs to happen. Secondly, we have to work with communities that have been historically traumatized by the field of medicine and the field of research to rebuild trust. We're not always just talking about Tuskegee. It was so many other issues outside of that. But that also impacts people's willingness to go to the doctor, right? And we have to build these relationships and be transparent and acknowledge what has happened and not act as if it didn't, right? That's very important. And then we need to work with families that we're servicing to help them to understand their family health histories. Precision health and precision medicine will only be as good as the information that individual can give to that physician so that they can be precise based upon what runs in their family, based upon what they are most likely to be exposed to, or diseases that they're most at risk for possibly developing. And so really understanding family health histories and encouraging family members to gather their own family health history or internal family medical record, have that information there, and that educating that family health histories is more than just a couple of forms on a clipboard you fill out when you go to the doctor's office, but it's an information source that will guide family members on how they could possibly live longer, healthier, and sustainable lives. And so I think it's a combination of several things. I'm gonna stop there for the sake of time, because you know I could dig a hole here.
No, Dr. King, you handed that baton to me perfectly, because I'm going to bring Dr. Gill up as we talk about people in the community who are doctors who want to come and serve the community. Dr. Gill is one of our resident physicians at Ascension Genesis. And I got to say, when I first met him, the first thing he said is, I want to be a doctor who comes back to my community. And he wants to do this work and is doing this work. So round of applause for you. Want to celebrate you, Dr. Gill, and uplift you in your training. Talk to us a little bit about your experience as someone who's a primary care doc, just returned to their area, and what you see in terms of misconceptions around prostate cancer.
Okay, absolutely. First of all, thank you for having me on today. I appreciate the opportunity. Coming back to Flint, of course, the reception has been great and sometimes overwhelming. The need for Black physicians in this community, people are excited, people seek the care. So that's something that I'm really excited about. A lot of people have misconceptions on when to get screened, how to get screened, what the symptoms are, and just generally what questions to ask their providers. So I'm finding in my position that I do a lot of question asking, answering a lot of questions from patients on when to do things and how to do things. A lot of people are just not aware of the risk of prostate cancer. They're not aware of where to even start with it. They're not aware of what type of doctors deal with it and treat it. So it's just a lot of information finding on the patient parts that need to happen. So I'm glad that we talk about social determinants of health. And I know that you mentioned a lot of it rides on patients just being equipped with the information. I think that the best thing that we can do as primary care providers is just offer the safe space for patients to ask questions and put things on their radar. I find that I have to put a lot of things on people's radars, whether it's prostate cancer, colon cancer screenings, mammograms. You constantly have to ask people, are they even aware if they're at the age to start screening for these things?
I think that's a wonderful, it's wonderful context, in part because as we talk about prostate cancer screening, there are different recommendations for prostate cancer screenings across different bodies, the American Cancer Association versus the American Cancer Society versus the Family Medicine Associations versus, you know, specific cancer bodies. And earlier in the talk, Dr. Ogunwobi mentioned the age of 45 as an age to consider screening. And there's also recommendations around 10 years before the first person in your family had prostate cancer, depending on when that was. it really highlights the need to be having these sort of one-on-one discussions with your primary care doctor, because your particular screening may be different than someone else's screening, your friend that you know, your cousin who might have something. So I really appreciate you highlighting the importance of screening. Dr. Ogunwobi, you talked a little bit about our different mechanisms for screening. You talked about the PSA, and you talked a little bit about the complications of the test from a science perspective. Dr. Gill, I wonder if you talk about why the PSA can be a difficult test to interpret in the office, and what are the things that sort of make it hard to say, your PSA is here, and that means this.
Yeah, so that's actually something I was talking about yesterday to a couple colleagues. The PSA can be triggered by so many different things. So it's really important for us to be aware of when those numbers are in a certain range. Just because it's slightly elevated doesn't necessarily mean that you have prostate cancer or that your risk is increased. They can be high above a certain range. It can be triggered, it can be elevated by things that are not problematic. You'll be surprised of the list, the laundry list of things that can cause an elevated PSA. But it's important for us just to be aware and address it. And when it does come up, have that conversation with the patient to decide when the risk is high, when the risk is low. Because for a specific elevated PSA, the patient's risk for prostate cancer can be either high or low. So you'll be surprised at how many people that ride motorcycles for long distances at a time could potentially have an elevated PSA. Those are things to consider and have those conversations with their patients about their lifestyle, but also just be proactive in what the numbers are showing and making sure that the patient is has a well understanding of what's going on.
Right. Thank you so much. Dr. Gill, and I'm going to give everyone sort of a last word. Any specific things you want people to look out for or think about in the context of prostate cancer? Any last comments, symptoms people should look out for, things you want people to know, things that you see people coming into the office and you wish you could just dispel right away? What are the things you want people to know to think about prostate cancer as we wrap up this conversation?
If I want my patients to, if anything feels different or if anything feels unnormal to you, you know your body better than I do. I can't tell you how something feels. If you notice that something feels different, please seek our attention, please seek care, and we can start to go down an investigative path for you and with you, most of all. Changes in your urinary habits, any pain or anything like that. You're getting older. Start to ask those questions and just seek help, and then we can go from there.
Fantastic. I want to celebrate the need for having a safe space and celebrate the people who have an opportunity to have a safe space with you. Dr. Key, any last thoughts in the context of prostate cancer, what we can do as a community to make sure people are aware of resources, prevention and treatment, et cetera?
Well, first, I just want to echo Dr. Gill's statement around really having those conversations with your physician and being comfortable having them and ask the questions that you may not, that you want to ask. But I also want to now flip the coin to the family. Have the conversations within your family. If you've had family members who've died from prostate cancer, uncles or grandparents, then have these conversations with the younger generation members of your family. And it's wonderful. Do this around holiday times, family gathering times. Some families still have Sunday dinners together. Do it then. Make it normalize health conversations at the family table. And then once you get that information, act on it.
Dr. Ogun, thank you, Dr. Key. Dr. Ogunwobi, any last comments?
Yeah, I think if there's anything I can add is I know that there's a lot of barriers to participating in research. Dr. Key talked about it, but I just would encourage a man and other members of our communities throughout the area to take advantage of opportunities to participate in research and clinical trials if you have a condition that they're inviting clinical trial participation for, or even other kinds of clinical research similar to the ones that I do. And as you can see, there are many people that genuine and are not going to cause harm. They go through the rigorous process of making sure that the research they do doesn't cause harm. It will benefit the community, and we encourage that because we don't want certain communities to be left behind when it comes to the benefits of precision medicine and precision health. Well, thank you again for listening to me this afternoon.
A personal thank you from me to you, because nothing could warm my heart more than getting to see you three Black men talk about something that is so important to a community. So super thank you from the bottom of my heart. Wonderful job. I'd like to segue us a little bit. We're going to have the Megan Landry from the American Cancer Society give us and talk to us a little bit about some resources for prostate cancer, but also, as all three of those wonderful men described, how important it is to listen and learn from your community and family. Megan Landry is going to be talking to us about listening to the voices of Black women. So thank you so much for being here today.
Yes, and what a great segue about the importance of participating in research, because this is really an opportunity to do so. But I didn't want to totally leave prostate cancer alone, since that was the main topic for today. So I just wanted to highlight a few resources ACS has around prostate cancer, like paper resources. We also have patient support for patients going through prostate cancer treatment, like rides to treatment, lodging, patient navigation services, but these are some of our brochures that we have as it relates to prostate cancer. So testing, understanding your treatment options if you have prostate cancer, and then there's a prostate cancer fact sheet for patients and caregivers. It's just a double-sided sheet on kind of summarizing what was learned today, and there's also a fact sheet for healthcare providers. So if family medical providers would like fact sheets to kind of keep on hand, that you can order these from the American Cancer Society at no cost to you. So I wanted to share that, but let's dive into Voices of Black Women, if that is okay, if you can go to the next slide. So Voices of Black Women, I'm going to talk all about what it is, but it is a new population cohort study from the American Cancer Society. You can go ahead to the next slide. So why does the American Cancer Society exist? Why do we need an American Cancer Society? Because the burden of cancer is unacceptably high. Can't tell you how many times a day I hear of somebody being diagnosed, or, oh, my grandma had this kind of cancer. It happens all the time. And those of us who work at ACS say and mean that if one day the American Cancer Society no longer exists because cancer is not a problem, we'd all be happy with that. Next slide. So the vision at the American Cancer Society is to end cancer as we know it for everyone, not just for a certain group of people, for everybody. And our mission is to improve the lives of people with cancer through advocacy, research, and patient support. Next slide, please. So the American Cancer Society, we have really three main pillars that we work through. Our discovery, which is really what this project falls under, and I'll talk about in a minute, but it's our research. We are the largest private nonprofit funder of cancer research in the United States. Our advocacy, so we are going to our state capital and to Washington, D.C. to talk to legislators about issues that cancer patients face and asking for them to support us. Things like reducing medical debt, making sure that medications are covered by insurance plans. Those are things that our advocacy team is working on. And then patient support, making sure that patients have rides to treatment, they have lodging, they're getting screened, they're navigated through their treatment. Those are the work that we do through patient support. Next slide. So a lot of people know that ACS does research and funds research, but something that people might not know is that we also have our own internal research department, our population research department. And so we've been doing these population cohort studies for the last 70 years, and it's to really understand how cancer develops in the population, and then how can we improve the quality of life after a cancer diagnosis. So we've worked with over 2.5 million research participants since 1952. And when participants join our studies, they consent to provide us with information over time. And so over time, we can see what changes research participants experience in their lifetime. That data helps us to understand what factors can contribute to a diagnosis. And we're also able to study what can contribute to survivorship. The studies are valuable for a lot of reasons. They're big studies. There's long follow-up of study participants, and there's geographic diversity. So what we can learn can be impactful across the nation. Next slide. However, as we talked about, well, I'm going to talk a little bit about some of the things that we've been able to learn because of these studies. So one thing that I always point out in this slide is that there's been a link between smoking and cancer, and that was found really through these population cohort studies. Now that is something that most people, the general public, know, but we didn't know that until we were studying it. Next slide. So in May 2024, we launched our population cohort study launched our Voices of Black Women study. Next slide. This is really the first time that we are looking at a specific population because, as you heard earlier, Black women have been significantly underrepresented in research studies. And we talked about disparities, but I'm going to pull them out a little bit more. There's critical differences between cancer diagnosis and deaths for Black and white Americans. We really need to learn more about what is causing these gaps and disparities. So those blue boxes, you can see that Black women have lower rates of cancer diagnosis overall for breast cancer, but despite being less likely to hear the words "you have cancer," Black women are more likely to die from their cancer diagnosis. And for some cancers like colorectal and some GYN cancers, Black women have both higher incidence and mortality from certain cancers. And so those are the reasons that we're working on Voices of Black Women to really understand that disparity. Next slide. So the overall life expectancy is lower for Black individuals versus white individuals. This large scale cohort of Black Americans can have substantial value even beyond cancer. So collectively, Black individuals have the highest death rate and shortest survival of any racial or ethnic group in the US for most cancers. Next slide. We want to engage Black women. We know that engaging Black women in this study is key to really understanding these disparities. It's been a limitation of past population studies, including at the American Cancer Society. It's been a miss. While we've enrolled a large number of Black women in our last study, Cancer Prevention 3, we identified a really critical need to launch a new study that would focus solely on the inequities among Black women. Next slide. So Voices of Black Women will be critical to help researchers understand what factors contribute to disparities so we can find the right interventions to eliminate them. It will not only be the largest study of Black women, but we will also be comprehensive in our data collection efforts to address the various factors that may be important. Next slide. So Voices launched on May 6, 2024. It will enroll 100,000 women in 20 states, Michigan being one of them. We are enrolling women between the ages of 25 and 55 with no cancer history, and they can reside anywhere in one of the Voices states. Next slide. Participation is the following step. It's an eligibility survey, informed consent, registration survey, life and health history survey, and then twice a year for 30 years, there will be a 30-minute follow-up survey. Next slide. So in that first survey, the life and health history survey, participants will answer a range of questions. Some of them are going to be standard questions that are commonly asked on health surveys, like your demographic information, family history. There'll also be behavioral and lifestyle information like diet, physical activity, and use of personal care products. But Voices is going to introduce a new data collection to help us better understand Black women's lives and experiences, including mental health, social support, and experiences of racism and discrimination. All of that information is going to help us better understand what affects Black women's health, and over time, this will guide us on how we can advocate for improved health outcomes for Black women. Next slide. So how can people get involved? So if you are eligible, we would invite you to get on our website and enroll in the study. We're looking for people to help us share the information within your networks. We have social media posts, newsletter blurbs, email templates. Discuss engagement opportunities if you want to figure out how to engage the company you work for, the organization you work for, or your social group. We can find ways to do that. We're also looking for Voices ambassadors. Ambassadors are women in the community. It can be men too, but who are really passionate about this and who say, you know, I know that I have a network that I can talk to about voices, and I want to help you enroll women in this study. I think most of you probably know that Dr. Latricia Gordon, I don't know if she's on today, but she is a Voices Ambassador. I think I saw Rachel Harris from Exact Sciences on. She is a Voices Ambassador. So we are looking for Voices Ambassadors. We are actually hosting a little get together at the end of August in Flint for people who are either supporters or ambassadors of Voices and want to get together and brainstorm and talk more about this study. You can learn more, including an updated FAQ. It's updated on the almost daily with new information at voices.cancer.org. I believe that's the end of the slides. Yeah, so I am here for any questions. Would love to hear questions. I know I kind of went through that fast, but I was trying to make sure we made it on time.
No, I super appreciate it. Tell us a little bit about, sorry, 1 second. I want to make sure we didn't miss any questions from the community. When you think about sort of what you've heard about your partners and their ability to get the voices out, what are you hearing as barriers? So some of your ambassadors are working to get the voices out in the community. Is there anything you've heard back that is sort of a barrier to getting this message out?
Yeah, I think one of the things that I'm hearing is that women are a little intimidated by the length of the study, that is 30 years. They're excited about it, but signing up for a 30-year study can be a little intimidating for people. And so I guess what I'm trying to do, and hopefully, get the message out about the reason that it's that long, is so that we can pull out information over time, and sub-studies will come from what we find. So if 5-10 years, we're finding great information, then some sub-studies are going to come out of that, and we're going to get even more information out of it.
Fantastic. And so tell us a little bit about how, when someone decides that they're going to sign up for the study and they sign up for this 30-minute interview, how does that take place?
It's all online. So you sign up you can use your personal computer, you can use your phone, you can use the library computer, however, and then you sign up through your email address and put your mailing address and phone number in as well. But you'll get notification for the next 30 years of when it's time to fill out a survey again.
Got it. And is there a process for which, if people, let's say someone is saying, gosh, I do want to sign up, but I'm worried about 30 years. Do we still can encourage those people to sign up? And what are the options for leaving the study? How do they let someone know? Not that we want people to.
Right. No, yeah, the study team is super active. And so if somebody were to say, you know what, I signed up, but I'm not sure I actually want to partake, then they could let our study team know and be taken off the list.
Fantastic. Any last comments, thoughts that you want to share about the study? This is so important, needed work that's happening in our community. So thank you.
Yeah, I think my last takeaway would just be to encourage people to check out the website. You can see who's on the study team, who's on the advisory board, and read all the questions that people have asked before today to kind of get a feel for really what the study is, who's behind it, all that great information.
Fantastic. How long is sign up?
It is going until we reach 100,000 women. So whenever we hit that, we have 62 in Michigan signed up so far, and about close to 2,000 nationwide. So the 100,000 is nationwide.
Fantastic. All right. Thank you so much.
Yeah, thank you.
Information, Megan, and we really appreciate your needed expertise. I want to talk about one more event that is happening before we end, and then there's one wonderful comment in the chat that I want to end on. So I want to talk about one event, and that is best practices in public health communication. This is an opportunity for those of you who have been on the webinar or have colleagues who are interested in providing material for the webinar. This is your opportunity to tighten up your skills in terms of delivering information that can be really complex to a really diverse audience. It's an opportunity to understand best practices for written and oral communication. And we've got some expertise at this Zoom workshop from Kayla Haber-Mayhill. I'm really sorry if I pronounced her name incorrectly. But this is an opportunity for you to tighten up your delivery of public health communication. So thank you so much to Heather Lynn for telling us about that event. The last comment that I want to leave us on was a wonderful comment in the chat from Kay, and it says, we should never forget that the Flint community made an enormous contribution to prostate cancer research in the 1990s. I was project coordinator for the U of M Flint Men's Health Study. Originally, research on age-specific distribution of PSA levels was conducted at Mayo with a sample of white men. The Flint Men's Health Study was a huge sample of hundreds of randomly selected African-American men who underwent PSA testing, transrectal ultrasound, and chromosome analysis. Dozens of publications resulted. And it highlights the extent to which people in the community are doing this work and are taking care of community. So thank you to Kay. Thank you to Dr. Ogunwobi. Thank you to Dr. Gill. Thank you to Dr. Key. Thank you, Megan Landry, for being here today and amplifying the voices of those who don't always have the opportunity to be amplified. A reminder about CEUs for community health workers. Thank you for being here today, and we look forward to seeing you next month.